Alright, a little bit of a different video today. I just kind of wanted to show off some skills that we've learned and have picked up along the way from professor guidance, textbook readings, and actual clinical experience. Now, I want to go ahead and get this disclaimer out early. I am a first-year CAA student at the time of this recording. I do take shortcuts, and I do not show the entire start-to-finish process intentionally for the sake of time. I filmed these myself, so I had to split my focus while recording. I have to have a path for the camera to record, so I have to get out of the way of it, which means my form is going to be awkward in some of these shots. I may or may not point it out as we go. Lastly, and likely most importantly, this is not medical advice. Talk to a physician. Do not try any of this at home, obviously. Now the skills I'm going to be showing today are going to be oral airway insertion, nasal airway insertion, LMA and I-gel insertion, intubating with a Mack and Miller blade, video laryngoscopy, spinal anesthesia administration, epidural anesthesia administration, IV catheterization, and central line placement. So let's get into it. And yeah, again, keep in mind, I'm a first-year student. I do not have my license, so if I perform this if I perform this on any patient, it is under one-on-one supervision with a licensed physician, okay, or licensed anesthesia provider. So I want to make that very clear. All right, let's get going. So to start out with, our first thing is going to be the oral airway insertion. Now, just for demonstration purposes, I'm going to be turning the mannequin head towards the camera. Now, these mannequins don't have tongues. I mean, they do have tongues, but they're not floppy tongues like they would be in a real person. So, using the tongue depressor is slightly overkill. However, on a real patient, it's often advised that you do this, and I believe it is actually the textbook way of going about it. So, using the tongue depressor to get out of the way, inserting in one fluid motion, and that's going to help open up this fake patient's airway. Now for the nasal airway insertion. Now one thing to keep in mind is this is plastic, and this entire mannequin is plastic. Now because it's soft plastic against soft plastic, there's going to be a lot of resistance. There's going to be a lot of resistance on nearly all of these procedures. So if I'm looking like I'm struggling to insert something or pushing really hard or having to do something over multiple attempts, it is because it is plastic on plastic. In a real human being, there's going to be secretions and saliva that will help lubricate this process. So I just want you to keep in mind that what I am doing is going to be an exaggerated version, right? I'm going to be having to push harder. I'm going to be having to have more aggression when inserting things. So in reality, it's a lot smoother. I just want to clear that up. Anyway, so starting out by pushing into the nasal cavity, and as my finger is going to indicate, you want to push straight down. You don't want to be pushing up towards the forehead. You want to be pushing down, basically in towards the ear along that axis. On this mannequin, I don't really have a choice. Again, it's just plastic, so I have to insert where it goes. And there it is inserted. Now for LMA insertion. Again, this is another plastic/rubber device, so it's going to get stuck and it's going to be a pain. Tongue depressor, get the tongue out of the way, using the Archie Brain technique, pushing down as hard as I can, tracing with that index finger up the hard palate, down the soft palate, and into the back of the throat. Again, because it's a mannequin, I'm having to really shove it in there. Going to inflate that cuff. And notice a slight shift in the tube. If you pay really close attention, you'll notice a slight tick. Just right there. And that means it's seated. And then you could hook this up and check it for airway patency and check for end-tidal CO2 to confirm placement. I-gel insertion, and I-gel is basically a very rigid LMA. So you can see the LMA. And then here's the I-gel going in. A little more straightforward of a process. Again, getting stuck, so I'm having to just shove it on in there. And then it's about that point. You could hook up the anesthesia machine or the ambu bag to confirm ventilation, and then carry on with the case. But very straightforward insertion process. You'll notice it's nearly identical. One of the main differences, though, is the technique with the traditional LMA involves tracing it with the index finger all the way down, while an eye gel, it's much more rudimentary, and I've seen practitioners who just effectively push it in there in one fluid motion without tracing at all. And there you go. And now for a Macintosh blade intubation, aka a Mac blade. And I'll show you that. And there we go. Mac 3. So Mac is the style, 3 is the size. And the key thing to note about this is the curvature of the blade. Millers are straight, Macs are curved. Now, this is one that was very difficult to do with the camera over my shoulder, have to be at a very awkward angle. You'll notice how my left arm is very outstretched. In reality, you do not want this. So I make sure I get a good view, insert the endotracheal tube, again, having to be forceful because it's rubber on rubber, pulling out our stylet while making sure our hand is firmly securing the tube. It's very important. Inflating the tracheal cuff. The goal is a soft bounce. You can see me check it right there. Disconnect. And then now you would hook it up to the machine or to the ambu bag and check for ventilation. You can also listen for bilateral breath sounds and to rule out gastric intubation, otherwise known as goosing the patient. And here's the actual view with a Mac blade. So you can see, just barely see, so there is the epiglottis, those are the arytenoid cartilages, and there's a little bit of white. That's vocal cord right there. And that is what I'm seeing. Naturally not this close, but you get the idea. There's my view. And yes, shaking because it's awkward. Now for the Miller blade. So if you remember, the Mac was curved. Miller is straight. Similar technique. Scissor the jaw open, insert the blade. Again, very awkward due to my outstretched arms because I have to have an angle to film in. Inserting the tube, getting it firmly in there, holding tight up against the jaw, removing the stylet, and once again moving to inflate the tracheal cuff. And this one, I don't check the bounce, I just go for it. And here's what the view would look like. So you'll notice there is no epiglottis in view because the Miller blade lifts the epiglottis. Now for video laryngoscopy. So you can see there's a little camera attached to the Mac blade. And I'm filming, important clarification here. Left hand with the blade, right hand on my camera. I have no way to scissor the jaw because I do not have 3 hands. In an actual scenario, you will not be inserting this one-handed, okay? You will be ensuring that the jaw is being scissored open, so you're clearing the teeth and there is no dental damage. It's a very important clarification. Again, in a real patient scenario, this would not happen. And I'm talking about this right here. In reality, my right hand that is currently holding my camera would be right here, scissoring the jaw open to increase the mouth opening distance and ensuring that I don't chip a tooth on the way in. Okay? And again, another thing that's not realistic is you'd want to sweep the tongue out of the way using the blade, but because this is a rubberized tongue that does not flop around, there's effectively no need to do so. Is it good practice? Yes. Is it impractical when filming one-handed? Also yes. So here you can see I'm tracing down the palate. Right there you can see the uvula on the soft palate. Tracing down, and there you can see the arytenoid cartilages. I'm trying to find the sweet spot. I'm still on the base of the tongue, There's epiglottis. Now the goal is to lift, and because of the rubberized plastic, it is very difficult to do on this. There is no vallecula to help lift. So I'm doing the best that I can one-handed. Here we can see our arytenoid cartilages and the beginnings of the bottoms of the vocal cords. Now, if On a patient you are struggling to do so, you can use this as if it's a Miller blade and actually lift the epiglottis manually. Okay? And then you can see I get a much better view by doing so. Now we're moving on to spinals, aka the big needle. And spinals and epidurals are the things that I have the least practice with, so you just have to bear with me. So to begin with, we're going to take some fake local anesthetic, palpate our landmarks. We're going to numb the skin, and then we're going to numb the path of the spinal needle. So again, I'm feeling for the vertebra, specifically trying to find the space between them. Going to make a little lidocaine skin wheel, W-H-E-A-L. Just numbing up the area, waiting for it to set in, and then you can trace the path that you want to take with the lidocaine needle, numbing along the way to ensure you have a path of anesthetized skin and tissue. And then in a real patient, we'd wait for this to set up. Now we have an introducer needle, and this is the needle that the needle goes through. A little jump cut for technology issues. Finding my path, finger on the posterior process, and then pushing in the introducer. Now in comes the spinal needle. Trying to line it up, it's a little bit finicky. And out comes the stylet. Now I'm going to be stabilizing, and I'm going to be making slow pushing motions with this hand right here until I can see cerebrospinal fluid flowing back out of the needle. And I say flowing, it's going to be a slow drip. So you'll notice very tiny movements to push it in. Checking after each little push. And I see it right there. So you'll notice it's a very, very slow creep out. It's not going to run out. It's very slow creep. And it's at this point that you could connect to this, and you could actually administer whatever medication that you were needing to give. And you just hook directly up into it. And in a real patient, again, you wouldn't let it flow like this. Now for an epidural, it's going to start very similar to a spinal in the sense that it's going to be palpating landmarks and then anesthetizing an area around the injection site. And then we're going to give our 2E needle a good insertion. So again, trying to palpate the same landmarks. And now we're going to begin insertion. Best thing is to just go very slow on these. So now I'm going to demonstrate the loss of resistance technique. So what I want you to pay attention to is when my finger covers the tip of the needle, I can't compress the needle. It's going to always bounce back. But when my finger is not covering the needle, it just collapses. So watch. Won't go, will go. Won't go, will go. So this is the loss of resistance technique. When you're pushing through skin and tissue, you will be fighting the resistance. The syringe will not collapse. However, once you enter the epidural space, it is a potential space within the spinal column, and it can fill with air or saline. So the moment that needle collapses, the moment the syringe collapses, you know that you have entered the epidural space. So that's why we use the loss of resistance technique, because it tells us, hey, we've exited the tissue, we're now in the epidural space. So I'm going to connect that to the 2A needle. Initial check right there. Stabilizing my hand up against the fake patient's back. And then again, very slow movements while constantly checking to see whether I have lost resistance. So tap, tap, tap. It doesn't collapse. And bingo, there we go. See how it collapsed in that time? I lost resistance, and I'm in the epidural space now. And it's at this point in which you could insert the epidural catheter, give your test dose, and verify correct placement, and then go ahead and anesthetize the patient properly. Now for an IV. Just going ahead and picking out one that looks nice. Putting on our tourniquet. It's generally accepted that the tourniquet goes on at the beginning. However, when to remove the tourniquet, I've seen it every which way, so I just leave it on for the entirety of this. It's important to clean the site that you're going to be giving the IV. You can use alcohol prep, you can use chlorhexidine, you can use any number of things. I'm checking which way the bevel is. You want the bevel up. That's the way we're taught, at least. So now here's what I want you to pay attention to, okay? You'll notice I have a free index finger. This is not pressing up against anything. I have my thumb and my middle finger holding the needle apparatus. Now what we're looking for is called flash. Now what flash is it's blood returning into this needle. So when we get into the vein, you'll notice blood is going to show up right here within this plastic. So that's what I'm looking for, and that's what you should look for too. So shallow angle, going in my insertion site, slow but steady advance. Bam, there it is. Right there. Now, the textbook way to do this is to drop your angle, insert a little bit more, and then with the free index finger, slide the catheter off of the needle. That way it's a one-handed operation. However, again, this is rubber. Humans are not rubber. The rubber is going to fight back, so you really have to use two hands to do it. But the textbook way to do it is to take this finger and flick it off, in the sense of flick the blue catheter off. It's not always blue, just talking for the specific example. So you notice I have to use two hands for this. And there we go. Now again, you're not just going to want to let it sit there. This is just because there's a camera. Put a little piece of gauze there if you'd like. Some people prefer it. You're going to want to occlude the vein. And again, some people pop the tourniquet here. I've seen people do it. I've seen people not. Really trying to occlude that vein. Hooking up our saline syringe that has been flushed. Pull back slightly. Oh, just a second. And there you go, venous blood. And then flushing it back in. And so at this point you can go through, secure it, and you have a working IV. Now for central venous catheter insertion. In this case we're doing right internal jugular vein. So let's break down what we're looking at right here. These are settings for the ultrasound machine. This is what the ultrasound probe is seeing. This is the ultrasound probe. And then here's me. So what I'm looking at is I'm looking right here. You see this circle? That is my target. All right, so again, that is going to be the right internal jugular vein. So I have my syringe. I'm going to put it just beneath the skin, and I'm going to pull negative pressure, basically making a vacuum. And one thing I want you to pay attention to is that when my hand jiggles down here, up here jiggles too. That's how I find the path of the needle. Negative pressure being pulled. Jiggle, 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 trying to find the tip of the needle. Once I find it and I'm confident, I'd continue to insert, and then bam, right there. If you missed it, watch. You'll notice the syringe fills with blue. And that's our simulated venous blood. And again, for theatrical purposes, I let go and give you guys a closer look. And a real patient, no, it is not blue. I feel like that goes without saying, but Next step is going to be to insert the guide wire, and in this case we can do a through the needle technique. You can't do that for all of them, but this needle allows it. Going to confirm guide wire placement. It's kind of hard to see, but there's a brief second where it comes through really clear even over at this angle. So here's the top of the vessel wall. Just beneath it, you'll notice a little hot spot. And what I say by hot spot is it turns bright white, like right here. Bingo, there it is. That's confirming our placement. So now I'm removing the needle, leaving the guide wire in place, holding pressure to prevent bleeding. Now we're going to put in the dilator. Again, we're just going to thread it down the guide wire. We know the guide wire is located within the target vessel, so we'll just thread it down in it. And again, you'll see me having to let go of things and pushing at awkward angles. Please keep in mind, this is a fake patient and it's rubberized, so I'm meeting a lot of resistance. And what you saw with my finger right there was this was a portion in time in which you could use a scalpel to slightly nick the skin and underlying tissue to allow the dilator to insert freer. Right there. Threading it in. Textbook says you will feel distinctive pops upon insertion as you're going through the tissue layers. And there we go. We now have the dilator over the guide wire, and we're going to take another look with the ultrasound. Another thing to note is there is no ultrasound jelly on this fake patient because I was lazy and did not want to have to clean it up. So again, we're checking for proper positioning, and you'll get a really good view right here. So if you can see this line right here, that's the catheter. I'm going to shake it with my hand, and you'll notice right up here it's going to jiggle within the vessel. And that, to me, confirms what I'm looking at is what I think I'm looking at. Now it's time to remove the dilator while maintaining the guide wire within the vessel. Otherwise, we have to repeat this entire process again. Now it's time for the actual central venous catheter. Thread it over the guide wire. It's important to not insert it until you have control of the guide wire so that you don't just send the guide wire into the heart. That can happen. And now we're just going to thread it down. There we go. And now we can check to see if we indeed still have proper placement. We can do this by pulling some fluid out of the catheter and ensuring it is still venous blood. So you notice I have air in the syringe. Again, not something you'd actually do, but there we go. We're still in because we got blue. And again, just giving it back because this is a mannequin. And there we go. So again, important message to end off. I am a first-year CAA student at the time of this recording. I do take shortcuts, and I do not show the entire start-to-finish process intentionally for the sake of time. I filmed these myself, so I had a split focus while I was recording, and I had to do some things at awkward angles that were not ergonomic, and yes, I more than likely made some mistakes along the way, which is why, in my current unlicensed state, I will always be monitored by someone who is licensed in anesthesia. This is not medical advice. Talk to a physician if you have any questions, and do not try this at home. And with that, I'll see you guys in the next video. Bye.